As we look at how to provide the optimal level of moisture to the surface of the wound, we must first be reminded of the importance of a complete assessment of the patient and their wound, as this is key to making appropriate dressing and treatment decisions. Exudate level or drainage is one of the many factors to consider when selecting a dressing for Mary. The primary goal is to create a moist wound environment, but also to protect her peri-wound skin from maceration and prevent strike-through or leakage from the dressing into the environment. The right dressing for the wound will not only prevent soiling, but also prevent transmission of bacteria to and from the environment. If Mary's wound is highly exuding or suddenly starts to produce more exudate, we need to investigate the reason behind this and commence our assessment from there. For example, this may be due to an infection, unmanaged edema, or necrotic tissue in the wound bed, all of which need to be addressed before we select an appropriate treatment for the wound and the situation. As we assess the exudate, we should consider the amount, color, type, and consistency or viscosity. The amount of exudate can be difficult to assess at first glance, because as we remove the existing dressing, we must know when her last dressing change occurred. A dressing that is fully saturated but changed a week ago is clearly different than one that was changed only a few hours ago. Wounds are dynamic, and it is expected that exudate levels will decrease over time, so the dressing being used needs to be evaluated regularly. There are a few things to consider as we evaluate the level of exudate. One is edema, an often overlooked component of the peri-wound or in swollen lower limbs that will influence exudate levels. Managing edema adequately will help to reduce the volume of exudate from the wound bed. When treating a venous leg ulcer, for example, and only compression wraps or garments are being used, there may be a larger volume of exudate as the edema decreases. So it stands to reason that it will be essential for the dressing to handle exudate by absorbing, retaining, and transporting it so it can evaporate from the back of the dressing. Another consideration, especially with an increase in exudate, would be the presence of increasing levels of bacteria and if there is accompanying malodor or color changes to the exudate. Local erythema or redness and an increase in pain may also point to infection being an issue. In this situation, we need to assess the wound for infection and use an antimicrobial dressing or combine it with antibiotics and debridement if that is indicated. Other reasons for a high volume of exudate can be the presence of necrotic or sloughy tissue. Be aware that during the period of debridement, this will decrease over time as granulation occurs and as the wound bed becomes cleaner. As we assess color, we differentiate this from the type of the exudate. Color can be influenced by a number of factors, namely the presence of bacteria, the presence of blood, as well as the previous dressing or treatment used. But the color of the exudate should be noted if it deviates from the normal for that patient, has an accompanying odor, or can't be explained by the previous dressing. Type, on the other hand, is described in 8 different ways, but the most common terms are serous, meaning containing serum, which is usually light yellow in color; serosanguinous, meaning contains both serum and blood, which is generally some degree of pink to reddish in color; sanguinous, meaning containing blood, which is actually frank blood; and then purulent, meaning pertaining to pus. A final consideration in exudate assessment is the consistency or viscosity of the fluid, which can be influenced by bacteria, protein, as with lymphedema, and white cells. Dressings capable of pulling higher viscosity fluid up into the body of the dressing and preventing of pooling at the wound bed should be used to prevent maceration of the peri-wound skin, but more on that on the next essential. Now that we have assessed the color, type, and consistency or viscosity of exudate, we need to select the most appropriate dressing and treatment plan together with the patient. In consideration of the previous descriptions of wound exudate, Dressing choices and treatment may be made by answering the following questions. Is the wound dry? Then use a hydrating dressing, such as a gel, or a dressing that will influence humidity. And speaking of dry wounds, if cells on the wound surface are allowed to dry out, then epithelial migration will be delayed. Cells will die if they become desiccated, so we should not expose wounds to air. Some wound types have specific underlying pathology, which can influence the treatment pathway. For example, if the wound is covered with a dry eschar on the lower extremity, especially in the presence of poor perfusion, the eschar should be left dry and protected with a dry dressing or a soft silicone wound contact layer, for example. Remember, if in doubt, contact the multidisciplinary team to create an optimal treatment plan. Even a foam dressing will create a humid enough environment to allow the autolytic process to begin at the edges. If there are structures like fascia, bone, tendon, blood vessels, or joints present, these should be kept moist with close attention given to microbial control. Additionally, any moving joint or tendon should be immobilized to allow for tissue growth. Is the wound draining or exuding fluid? Then use a dressing that can both absorb and retain the amount of exudate. Additionally, wear time of the dressing is critical, especially with the use of a compression garment or a cast that will be left in place for up to 7 days. It is important to maintain the optimal moist environment and temperature, and if there is a clean, granulating wound bed, leave the wound undisturbed for as long as possible, for example, up to 7 days. Is there space in the wound? If there is a cavity, undermining or tunneling present, this space should be gently filled with a dressing that can absorb, retain, and also transport the exudate to the secondary layer. This will help to avoid pooling of fluid on the wound bed and in deeper spaces. With all this said, let's turn to Mary's wound. Wounds on the lower extremity are often compromised by edema and need to be investigated. For Mary, the use of compression on the lower leg will enhance her healing potential and help to reduce the exudate from the wound. In the early treatment phases, an absorbent gelling fiber covered with an absorbent foam was required to enable the wearing of the compression garment for up to a week. As the edema reduced, then the need for absorption was lessened, and the dressing management was changed to reflect the difference in the drainage. Now Mary's wound is clean and granulating, and her skin surrounding the wound is intact and free from maceration or erosion, which can indicate good exudate management. Our goal now turns to covering and protecting the wound and leaving it undisturbed for as long as possible, or at least the length of time the dressing is indicated. Application should allow for minimal to no pain on application and removal. For Mary, we have decided to use a silicone-bordered foam dressing for absorption, retention, and protection, as it can stay on the wound for 7 days for undisturbed wound healing, promoting a moist wound environment and which is also compatible with compression therapy. So now we have covered the topic of our 6th essential, moist wound healing. Let us continue our journey as we turn our attention to number 7, which is closely related: taking care of the peri-wound and surrounding skin.